Good morning, everybody. Assalamu alaikum. First of all, I would like to start by thanking and congratulating the organizers, especially Dr. Ahmed Al-Askar and the whole SSBMT leadership for this lovely event. This event has become a well-established tradition, and I think you can all be proud of this achievement more than 10 years after its launch. And a big thank you for all the colleagues in the Kingdom and in the Gulf region in general for everything you're doing to advance and improve patient outcome in the region and beyond. So as part of this post-Congress activity, I have been asked to give you a summary about the management of GVHD from prophylaxis to therapy. And one may wonder whether there is anything new in the field of GVHD. And I'll try to convince you that there is a lot of advances. I'll be very straightforward, and I think everybody's convinced that now the use of high-dose post-cyclophosphamide that was introduced by Leo Luznik, Paul O'Donnell, Ephraim Fuchs, and many others from Hopkins has been a sort of a seminal advance in this field. And I'm sure most of you are familiar with this slide about the original design of this so-called post-Cy platform in the haploidentical transplant field. Of course, it has been modified since because we're not using anymore the small dose of cyclophosphamide as it has been established in mice. And of course, now we use 2 days of post-Cy. And the initial results are shown here. Clearly, you have a significant control and decrease in the incidence of severe acute GVHD, but also in the incidence of extensive chronic GVHD. But this was in the bone marrow setting, bone marrow as a stem cell transplant source. With this background, with these data, I think the community started using widely post-Cy for GVHD prophylaxis in the haploidentical setting. And then automatically, the key question one can ask, why can't I use post-Cy for GVHD prophylaxis in the mismatch setting? And this is exactly what has been done in this work from the Acute Leukemia Working Party of the EBMT, published now more than 4 years ago, actually, showing that using post-Cy in the HLA mismatch unrelated donor transplant is able to decrease significantly the incidence of severe acute GVHD compared, for instance, with ATG, which is historically the standard of care. But not only you have a decreased incidence of severe acute GVHD, but this will translate into a better survival. And this was established in the setting of acute myeloid leukemia, which represent today the key indication for allo transplant. So we know today that in the mismatch setting, also post-Cy is widely used. But of course, outside the haplo and the mismatch setting, is there a role for post-Psy? And in the matched unrelated setting, for instance, but also in the matched sibling donors, we know that the use of rabbit ATG is very well established. And we do have prospective randomized trials, mainly in the unrelated setting, only one trial in the matched sibling setting, clearly establishing the value of ATG for GVHD prophylaxis in the myeloablative setting. And this is why in European countries, ATG is the backbone for GVHD prophylaxis in the matched unrelated donor and in myeloablative conditioning transplantation, but also in reduced intensity conditioning transplantation. We have performed a randomized trial in the reduced intensity conditioning setting using standard approved in Europe conditioning fludarabine, IV busulfan, ATG thymoglobulin with cyclosporin and MMF versus fludarabine, IV busulfan, and post-Psy plus cyclosporin MMF. And this was in the matched sibling donor and in the fully matched unrelated donor. And this study received the EBMT 2021 Van Beckham Award and was recently accepted for publication with a relatively long follow-up. And the bottom line is here, the results, the cumulative incidence of relapse is similar between ATG and post-Psy. Cumulative incidence of non-relapse mortality is similar. And at the end of the day, leukemia-free survival is similar. So it looks like, although this study, the primary endpoint was about showing that maybe post-Psy is better, actually it doesn't look like to be better. So post-Psy is here to stay. It is well established. However, probably if you have already an important experience with post-Psy, you know that it has some glitches. It's not as easy as it appears. And already 4 years ago, and since we started using post-Psy, and actually our first patient who received post-Psy, believe it or not, actually are from a protocol which started in 2006. So that was quite a long time before post-Psy became routine and standard of care. And we immediately could notice that high-dose post-Psy, as developed by the Hopkins group, namely 50 milligram per kilo per day for 2 days, can lead to some important early cardiac toxicity. And this will have an impact on the overall survival. And this is important because the population that we transplant more and more is an elderly population with comorbidities. And we know very well, and I think this is very relevant to you in the kingdom, that cardiovascular comorbidities are a matter of concern. So with this description, with this in mind, how can we do better? Actually, we started immediately by reducing by 20% the dose of post-Psy. And that was a single center analysis that we published in 2023, in April 2023. And we could show that actually you can reduce by 20% the post-Psy dosage in the haploidentical PBSC setting. And of course, these were elderly patients where we thought they have a risk of cardiac toxicity. And we were very pleased to see that there is no difference when it comes to acute or chronic GVHD, any grade. So very good findings, single center, of course. But most importantly, we could see that we have less BK virus-related hemorrhagic cystitis. And most of you are well familiar that that could be a matter of concern in those patients when you use high-dose post-Cy. And actually, we have even a quicker platelets and neutrophil recovery. So really very good news. I was very pleased to see a few months ago that our Japanese colleagues were able to reproduce our findings. And what we are currently doing to further optimizing the post-Cy platform in the PBSC setting. And why we're focusing on the PBSC setting? Well, because this is the major source of stem cells, but also we know that in contrast to the original experience with bone marrow published by Hopkins, when you use PBSC, actually, the risk of acute and chronic GVHD is higher. And one idea is actually, in order to improve the safety, so reducing the dose of post-Cy, but also improve the efficacy, adding a small dose of ATG. And we started doing this almost 10 years ago, 2013, actually. And we published 2 years ago our original experience looking into the 100 milligram per kilo versus 70 milligram per kilo of post-Cy plus ATG, of course. And this has been published. It's open access. You can see the data. But again, you can reduce the post-Cy dosage by 30%. You can add a small dose of ATG, thymoglobulin 2.5 milligram per kilo, and actually you can gain in terms of GRFS. And we know that this is an important endpoint for us in the field. And now what we are currently doing, we're actually doing a phase 3 randomized trial, a national trial in France. And hopefully in a few years, we'll get these results. So you can see the prophylaxis setting is moving very nicely, but things are also moving in the management, for instance, of steroid refractory acute GVHD. I won't spend a lot of time explaining ruxolitinib has been a major advance established thanks to this phase 3 randomized trial, the REACH2 trial, and ruxolitinib has become a standard of care. But now we are faced more and more with patients who are ruxolitinib refractory and steroid refractory. And with a group of colleagues, we have set the frame to define these patients who are ruxo refractory for their acute GVHD. And this is where we need novel options. And this is where fecal microbiota transplantation, the transfer of microbiota, and we're currently developing this product, transforming the fecal material into true drugs, clinically validated, MAT13, which is an enema, MAT33, which is the oral form, the capsules. And at the last EBMT meeting, my colleague, Professor Malar, presented the compassionate use, the European compassionate use of MAT13, the expanded access program. Of course, these are ruxolitinib and steroid refractory. And again, we have a very nice overall response. And the majority of responses are CR and VGPR. And actually, the outcome of those patients who achieve CR, VGPR, or PR is going to be improved. We have actually 58% overall survival at 1.5 years. And currently, we are running a registration trial in this population, and hopefully we'll get these results in a few months. GVHD management is also improving not only in prophylaxis, not only in the acute setting, but also in the chronic GVHD setting. And we have some very good news when it comes to steroid refractory chronic GVHD. Ibrutinib, I think you're well aware of it. Although I think in Europe, in the Middle East, it's not very popular. Ruxolitinib is clearly now a standard of care thanks to the REACH-3 trial. But also now we have a ROCK inhibitor, namely belumosudil, which is making a true difference in the life of many patients, and it was approved by FDA. So here you can see the results of the REACH-3 trial, ruxolitinib for steroid refractory chronic GVHD, a clear and significant difference compared to the best available therapy. And this is why ruxo now is widely used. But we have now this newcomer, belumosudil, in the Rockstar study, heavily pretreated chronic GVHD, including patients who received actually and failed ruxolitinib. And you have an overall response rate of 76%. Very quick response in less than 2 months, and this is a long-lasting response. But the field of steroid refractory chronic GVHD will continue to evolve. I'm sure you will see very soon some data with a novel agent, a monoclonal antibody, a monoclonal antibody anti-CSF1 receptor, namely axatilimab. So watch out for axatilimab. So in summary, I think we can reasonably conclude that POSI is now well established for GVHD prophylaxis, including outside the haplo setting. However, we still need to optimize the POSI platform by dose reduction, maybe combining POSI and ATG. In the steroid refractory acute GVHD, we have ruxolitinib, very well established, but unfortunately, we have patients who will not respond to ruxo, who will be resistant to ruxo, and this is why you need other options, and modulation of the microbiota is proving to be successful, and hopefully we'll get some good news in the next few months. In steroid refractory chronic GVHD, again, the field is moving very nicely. We have ruxolitinib, we have belumosudil, and maybe another agent very soon. So you can see the field is really moving nicely, and this is really good news for the field, but also for all the patient, because we should not forget that allotransplant remains a potentially curative option for many patients who don't have other options, especially those patients with mild malignancies. So with this, I'd like to thank you all for your attention. I would like to wish you a successful meeting, and inshallah, we will be able to meet at some point in person. So thank you very much, and I wish you a lovely meeting. Thank you.